Anyways, I would like to thank you all for joining us here today for this very important meeting. On September the 22nd, 2016, just about a week and a half ago, the House of Commons Standing Committee on Health adopted the following motion from MP Don Davies, that pursuant to Standing Order 108-2, the subcommittee undertake an emergency study of the opioid crisis in Canada. So today we will begin that study, and we will continue on this study for several meetings. It is my hope that the witnesses in their testimony focus on solutions, specifically solutions the federal government can participate in. There is a problem here in Canada, and it is well known. There is one fentanyl overdose death every 14 hours in Canada, and the problem is getting worse, and we need to act very urgently. We have a variety of witnesses lined up who will offer their own unique perspectives and suggestions. We know that there is no silver bullet solution, so this study will be important in providing us with a toolbox of solutions that we can consider. And I appreciate that we are all concerned about this issue, and with that, let's hear from our witnesses. So to start off, I'd like to introduce let's see here, some witnesses from Health Canada we have here. We've got Hilary Geller, who is the Assistant Deputy Minister for the Healthy Environments and Consumer Safety Branch at Health Canada. She holds a degree in Business Administration from Toronto and York, and she has been with Health Canada since 2007. So welcome, Hilary. We've got Supriya Sharma, and she is a Senior Medical Advisor to Ms. Geller. She is a medical doctor and has a Master's in Public Health from Harvard University, and she has been with Health Canada for almost 12 years in various roles. We also have from the Canadian Centre on Substance Abuse, right over here. Sorry, I didn't say hi to you earlier. And this is going to be a challenge. You are Rita Notarandrea. I pronounced it correctly? Boy, perfect. Thank you. Rita is the CEO of the Canadian Centre on Substance Abuse, and she has been with the CCSA for 10 years. Previously, she spent 21 years with the Royal Ottawa Hospital in a large psychiatric institution, or it is a large psychiatric institution, including 13 years as a CEO there. So welcome, Rita, as well. And we have, I guess, I don't have any information on, let's see, okay. I can't quite see your neighbor. The gentleman beside Rita there, you're Matthew Young. You're Matthew Young. Okay, yes. You're with, where's Matthew? Oh, yes, okay. I'm sorry I don't have any biography on you, Matthew, but it is Matthew Young with the Canadian Centre on Substance Abuse is here as well. So maybe you could tell us all about you when you're up. Also, we have from the Royal Canadian Mounted Police, we have Todd, is it Sean? Shane? Sheen, sorry, Todd Sheen, and he is the Assistant Commissioner for Federal Policing Special Services at the RCMP, and this division has responsibility for border integrity and national intelligence coordination, among other things. Mr. Shane has been a police officer for 30 years. When in the rank of Chief Superintendent, he was responsible for national drug and organized crime operations. And we also have Luke Shaquin. Luke, I just have your business card here, so I'll just read that. Luke, the National Drug Program Coordinator at the RCMP, at the Federal Coordination Center here in Ottawa. So I think I did not. I have also Carolyn Xavier here from the Canadian Border Services. Carolyn is the Vice President for Operations, and she has a master's degree from Dalhousie and an executive diploma from Harvard. And she has been with the CBSA for about 6 years. CBSA has responsibility, of course, we all know, for securing Canada's land and maritime borders. We also have Mr. Brent Diverty. Sorry, Brent. He is Vice President for Programs at the Canadian Institute for Health Information. And he has a master's degree in economics and has previously worked for Stats Canada. He recently spent 2 years working with the equivalent agency in Australia. So, welcome to everyone. I would like to maybe just quickly go around our table here to introduce my colleagues to you. We can start with Darshan.
Darshan Kang, Member of Parliament, Calgary Skyview. Good morning, everybody.
John Oliver, Member of Parliament for Oakville. Good morning.
Randeep Sarai, Member of Parliament, Surrey Centre.
Doug Ailson, Member of Parliament for Charleswood, St. James, Assiniboia, Headingley in Winnipeg.
Good morning, Sonia Sidhu, Member of Parliament from Brampton South.
Good morning, Ron McKinnon, Member of Parliament, Coquitlam, Port Coquitlam.
Colin Carey, MP for Oshawa.
John Davies, Member of Parliament from Vancouver Kingsway. Thanks for being with us.
And Rachel, to quickly introduce yourself.
Sure. Hi. Sorry. Rachel Harder, Member of Parliament for Lethbridge, Alberta.
All right. Well, we'll get started with the presentations here now. And I guess we've got round one here. And we will start with, I guess, the Department of Health, Hillary and Supira. So.
Thank you. Thank you, Mr. Chair. Good morning. And on behalf of Dr. Sharma and Brent Diverty and myself, we'd like to thank you very much for the opportunity to appear today. As you know, British Columbia is at the epicenter of the current crisis of drug overdose and deaths, with the BC Coroner's Service reporting that there was a 62% increase in illicit drug overdoses from January to August of this year compared to the same period of last year. And according to the BC Centre for Disease Control, if this trend continues, BC could see 800 illicit drug overdose deaths by the end of the year, with nearly half of those expected to involve fentanyl. And yet the most recently available national data from the Canadian Tobacco, Alcohol and Drug Survey did not show increases in the use of the most common illicit drugs. So what has changed? What seems to be accounting for the unprecedented rise in deaths is the increased presence of fentanyl on the illicit market, an opioid that is significantly stronger than morphine. According to the BC Coroner, there were 264 illicit drug overdose deaths where fentanyl was detected from January through July, a 222% increase from the same period in 2015. Insight, one of 2 supervised consumption sites in Canada, recently began providing test strips as a pilot project at their site so that users of their services could test their drugs. And they report that 86% of those samples tested positive for fentanyl. As you'll note out here from the CEO of the Canadian Centre on Substance Abuse, the Canadian Community Epidemiology Network on Drug Use flagged that deaths linked to fentanyl have increased markedly across the country. And as you will note out here from our colleagues from the RCMP, this also reflects what law enforcement is seeing. So, while illicit drug use has always been a high-risk behavior, with the exact composition and strength of the substance being unknown, fentanyl has increased those risks immeasurably. As British Columbia's Chief Medical Health Officer, Dr. Perry Kendall, has said, no one is immune. People with long histories of drug use are overdosing, as are people trying drugs for the very first time. In terms of critical actions to deal with the immediate crisis of overdose and death, many experts are calling for 3 things: increased availability of naloxone, increased availability of supervised consumption sites, and increased availability of treatment, including medication-assisted therapies. Health Canada is responding to each of these 3 calls to action. We have made naloxone more widely available by removing the requirement to have a prescription. This was the first time that Health Canada initiated the removal of a prescription requirement for a drug to respond to a public health need. In addition, the Minister of Health issued an emergency order on July 5th to allow immediate access to the more user-friendly nasal spray form of this medication. And I'm pleased to note that yesterday it was announced that the department has completed its expedited review of this nasal spray form of naloxone, thereby regularizing its availability in Canada. In the case of supervised consumption sites, evidence has shown that when properly established and maintained, they can save lives, all without increasing drug use and crime in the surrounding area. These supervised consumption sites decrease the number of deaths by overdose and they can redirect injection drug users to health and social services. In addition, they reduce public drug use, rates of infection, and unsafe syringe disposal. I would like to note that Health Canada has heard concerns with regards to the legislative requirements contained in the Controlled Drugs and Substances Act related to the establishment of supervised consumption sites. Further to direction from our minister, we are working closely with potential applicants to explain the legislative requirements in order to ensure that there are no unnecessary barriers for communities who wish to open such a site. In addition, we are looking at the legislation to assess whether amendments may be advisable. In this context, it's important to recognize that the application review and authorization process seeks to ensure that supervised consumption sites are established based on evidence and with sufficient support so that these sites will be properly maintained. These rigorous criteria protect the health and safety of both the clients and the staff and give confidence to the community that there is a process in place to ensure that these facilities are operating responsibly. Health Canada is also supporting access to medication-assisted treatment options. For example, a regulatory amendment was recently published to allow for the consideration of applications for medical-grade diacetylmorphine under Health Canada's Special Access Program, as scientific evidence supports the use of heroin in select cases for the treatment of chronic relapsing opioid dependence. This same type of medical treatment with heroin under very specific circumstances has also been used in several European countries and provides a treatment option for the very small percentage of patients who have not responded to other treatments. Cet hiver, nous avons également l'intention de...
This winter, we intend to consult players in the field on regulatory requirements that would allow doctors to benefit from an exemption in order to more easily prescribe methadone, to see if the requirement that they follow normal practices is an obstacle.
And making evidence-based decisions, including as it relates to medication-assisted treatment. Through the Canadian Institutes of Health Research, we are making important investments in research to help build the evidence on which key policy decisions are made. The Optima study is just one project the CIHR is supporting. It will compare and evaluate the effectiveness of two treatments for prescription opioid dependence, methadone and the combination of buprenorphine and naloxone, with the goal of generating practice-based evidence that will inform patient care and improve health outcomes in Canada. Beyond the harm reduction measures described above, I anticipate that others, including the RCMP, will highlight the importance of addressing the supply side of the opioid crisis. Within the purview of Health Canada, the intention to put forward regulatory amendments to control 6 chemicals that are used in the illicit production of fentanyl was announced last month. The comment period for this regulatory proposal closed yesterday, and we will be moving forward expeditiously to control these precursor chemicals. The Minister of Health has also stated that she intends to bring forward legislative options for consideration on the issue of pill presses. Stepping back from the immediate crisis of overdose and death, it's important that the numerous individuals and organizations with a role to play in addressing various aspects related to the root cause of the opioid crisis come together. It's only by taking a collaborative, a comprehensive and evidence-based and sustained approach that we can make a difference in the long term. Important foundational work is well underway. Following the 2013 HESA report on the government's role in addressing prescription drug abuse, the Canadian Centre on Substance Abuse's report First Do No Harm, and the input of many stakeholders, Budget 2014 funding of $44 million over 5 years has allowed many of the initiatives identified in these studies to move forward. To give just a few examples, updated opioid prescribing guidelines will be available early in the new year. 19 new inspectors have been hired and are on track for over 1,000 inspections of community pharmacies. Public awareness campaigns have been run. The Canadian Institute for Health Information is using $4 million in funding to strengthen surveillance and data collection. And the First Nations and Inuit Health Branch of Health Canada is investing $13 million over 5 years to increase support for improved training for community-based addictions workers and to establish crisis response teams. Building on this, Minister Philpott called on the department in April to look at all possible options to take action in addressing this crisis. That work led to Minister Philpott's announcement in June of a 5-point action plan, which aims to influence the root causes and reduce the potential for harm, both in its most extreme manifestation as an overdose death, but also for so many other Canadians who experience harm from problematic opioid use. Given the challenges and complexities of this public health emergency, it's clear that our response to the crisis requires leadership among many different players, as well as a coordinated approach. To quote the Canadian Medical Association in a statement they made last year, the unfortunate reality is that no single level of government, no single health provider group, and no single sector of our society can resolve this complex crisis on its own. For this reason, the Minister of Health and the Honourable Eric Hoskins, Ontario's Minister of Health, as co-chairs of the Conference of Federal, Provincial and Territorial Ministers of Health, will be co-hosting a conference and summit in the middle of next month to discuss the current problem of opioid misuse in Canada and to identify further potential ways forward. The smaller summit following the conference will bring together individuals and organizations who have both the authorities and the commitment to take concrete action in combating the opioid crisis. I'd like to thank the committee for the opportunity to speak to you today. Mes collègues et moi serons heureux de répondre à toutes vos questions.
My colleagues and I will be pleased to respond to your questions. Thank you.
Great. Well, thank you, Ms. Geller. We'll move on to our next presentation. Brent Diverty from the Canadian Institute for Health Information. Brent, go ahead with your presentation.
I'm actually not here with a planned presentation. I'm here supporting Hillary and answering any questions you have about some of the data we have available to look at this issue.
Great. Thanks, Brent. And then we'll move on to the Royal Canadian Mounted Police, and we'll start with Todd Shane. Todd?
Good morning, Mr. Chair, and thank you for the opportunity to speak to the committee here this morning. As we are well aware, there's been a staggering increase in opiate overdoses in Canada, both lethal and non-lethal, which is the reason this issue must be treated as a crisis. Canada and the U.S. have been facing a similar crisis related to the abuse of opioids, causing large incidents of overdoses. As such, the U.S. has had the most fatal overdoses from opioids in the world, while Canada follows in second place. La croissance du nombre de surdoses et de décès dus à l'usage d'opiacés.
The increased number of overdoses and deaths can be linked to the use of pharmaceutical opioids, as well as the increased availability of access to illicit opioids such as fentanyls. The highly potent nature of synthetic opioids is well documented. In particular, fentanyl is estimated to be 100 times more potent than morphine. The mere exposure to it, whether it is via inhalation of airborne powder or absorption through the skin, can result in serious and life-threatening consequences.
Seizures of illicit fentanyl have been made all across the country, and this continues to increase. Important seizures continue to be made on such a regular basis in the area of the country such as British Columbia, Alberta, Saskatchewan, and Ontario, where high numbers of overdoses are also being reported regularly. The current upsurge in illicit fentanyl is expanding geographically, facilitated by known organized crime groups and local drug trafficking networks. The constant demand has promoted the illicit importation of several analogs to fentanyl. For decades, Canada-based organized crime networks and drug traffickers have produced illicit synthetic drugs in both powder and tablet forms. Illicit fentanyl has been accessed as a replacement to conventional drugs of abuse, as well as used as an additive to other drugs, often without the user's knowledge. Fentanyl is a significant concern, but the illicit opioid market is evolving at an alarming rate. As a primary example, in December 2015, a substance known as W18 emerged in Canada in what was thought to be a fentanyl seizure. Also imported from abroad, it is reported that W18 is 100 times stronger than fentanyl and known to be fatal in very small doses. Les enquêtes ainsi que le renseignement.
Investigations and intelligence reports that British Columbia is the main distribution point for fentanyl tablets and is the most affected province. This may be due to its geographical situation in relation to the main producer of fentanyl in the world, China. Domestic production of fentanyl has also been identified, but in low numbers. Our federal investigators are currently working on a variety of investigations involving fentanyl importations. Shipments are coming into Canada disguised or labeled in a variety of ways, such as printer ink, toys, or DVDs.
Pure fentanyl is diluted using cutting agents and is then manufactured in the final product, which can be in tablet form or powder form in clandestine labs before being distributed throughout Canada and to a lesser extent the U.S. Illicit fentanyl trafficking offers a significant profit margin. By way of example, it is reported that the raw material cost to produce 1 million fentanyl pills is under $100,000, but once sold, these tablets can yield profits of upwards to $20 million. These profits, coupled with easy access to supply markets and a growing demand, is likely to mean that the situation will not abate anytime soon. Recognizing the potency of synthetic opioids as highlighted the immediate urgency to ensure the protection and safety of frontline police officers, border officers, postal workers, and the public writ large. As a result, the RCMP has engaged in a number of safety awareness initiatives for frontline officers and the general public. Depuis un an, et plus récemment encore, la
In the past year and more recently, officer safety bulletins were distributed throughout the RCMP addressing the safe handling of unknown substances, including fentanyl, and outlining the risks, hazards, and necessary precautions that must be taken. We have made presentations to the provincial law enforcement community and other government departments, as well as publicly releasing a video via social media, which highlights some of the dangers that synthetic opioids pose to first responders and the public, and steps to protect themselves if there is a suspicion of possible exposure. The RCMP has purchased 13,700 naloxone nasal spray kits, which were distributed across the force. Naloxone is an antidote to fentanyl that quickly reverses the symptoms of exposure to fentanyl and other opioids.
Operational police officers and employees who are at risk of accidental exposure and who may be required to provide first aid treatment to citizens in an emergency situation and if an opiate overdose is suspected. The RCMP has developed mandatory training for officers and operational policy that addresses fentanyl and other opioid overdoses. With respect to collaborative efforts, the RCMP continues to consult with various stakeholders on outreach materials and is currently working to produce additional awareness products to help police, youth, and parents understand the impact of fentanyl. D'où proviennent donc ces opiacés de synthèse? Selon des rapports provenant des renseignements criminels et enquêtes de la GRC, on estime que la Chine constitue le principal pays source de ces drogues qui sont acheminées au Canada, particulièrement le fentanyl. La menace croissante de la part du fentanyl.
We have some translation problems here. Sorry.
There are illicit, where are they coming from, according to the RCMP, criminal intelligence reports and investigators?
Continue in English if that would be easier.
Perhaps maybe start off the paragraph again.
Okay.
Thank you.
D'où proviennent?
Where are these illicit synthetic opioids coming from? According to RCMP criminal intelligence reports and investigations, it is apparent that China is the main source country for these drugs entering Canada, particularly fentanyl. The growing threat from fentanyl, related precursors, and other novel synthetic opioids is directly correlated with the huge industry producing these substances within China.
And those based in China is the Internet. Via the surface web and the dark web, which enables criminals to anonymously create global supply chains for a range of illegal goods and services and acts as a platform for criminal expert forms. The RCMP has been building relations with our law enforcement counterparts in China in an effort to strengthen collaboration wherever possible to combat criminal activities with the goal of disrupting international drug trafficking networks. In October 2015, the Chinese government completed regulatory amendments controlling 116 new substances, including some fentanyl analogs. However, the drugs that made it to Canada are not controlled in China. In addition, there's a disparity between what Canada and China considers public health crises simply based on population numbers. Also, fentanyl abuse has not been identified in China. The Chinese government focus is on other synthetic drugs of abuse like methamphetamine and ketamine. Tel que mentionné précédemment, nos homologues américains font.
As mentioned earlier, our U.S. counterparts have also been faced with the illicit synthetic opioid epidemic and have identified Mexico as their main source of distribution. However, it must be noted that the drugs that are entering Canada from China are also found in the United States. The RCMP is working at home here in Canada with other government departments to raise awareness about this challenge, gather data on the scope of the problem, and collaborate with communities to stem the flow of illicit synthetic opioids that are having such a destructive impact. Alerts were put out as early as June 2013 by the Canadian Centre on Substance Abuse. Internationally, the RCMP has liaison officers and analysts who are deployed all around the world. They are tasked with providing direction, support, and assistance to Canadian law enforcement agencies in the prevention and detection of offences relating to Canadian laws. As such, they liaise with foreign agencies and develop partnerships to address issues of concern to the RCMP and the Canadian government.
Participates in the International Narcotics Control Task Force, a form of countries to discuss both domestic issues as well as investigations with international dimension. Over 30 countries, including China, participate in the task force, and we have used this focus group to share information in relation to the Canadian opioid crisis. Discussions at these meetings can strengthen international cooperation by assisting respective countries in considering amendments to their regulatory framework. In addition, initiatives are being proposed in international fora such as the G7 law enforcement project groups to address issues such as equipment and new technologies that facilitate the ability to manufacture pills made from bulk active ingredients. Criminals are profiting from new psychoactive substances that haven't yet been regulated to import these powdered bulk ingredients. As such, law enforcement must think of novel ways to mitigate the presence of these threatening substances within our country. Permettez-moi d'être clair, aussi longtemps que des entités criminelles au Canada.
Let me be clear. As long as criminal entities in Canada maintain vested interests in the opioid market, its expansion will likely continue to accelerate. Continued collaboration and support from Canadian agencies, government departments, and our international partners will be necessary to combat this issue.
Taken underway or under consideration across Canada will significantly assist in the prevention of fatal overdoses, advancing deterrent strategies, and developing early warning systems to rapidly identify and respond to high-threat opioid substances circulating in the illicit market. Thank you for this opportunity to speak with you today. I look forward to your questions.
Great. Thank you very much, Doug. We'll move on to Carolyn Xavier from the Canadian Border Services Agency. Thanks, Carolyn.
Bonjour, am I on? Bonjour, Monsieur le Président et honorable membres.
Good morning, Mr. Chair and honourable members. I'm Caroline Xavier, and I'm here on behalf of the Canadian Border Services Agency in my capacity as Vice President, Operations Branch. I'd like to thank the committee for the invitation to speak to you today. The opiate situation in Canada is a subject of immediate and ongoing concern for the CBSA. Our mandate to keep Canadians safe encompasses a wide range of enforcement and facilitative activities, not least of which is the seizure of harmful drugs at our borders. Part of our job is to interrupt the flow of drugs through our borders. This is a job that requires a combination of partnerships, technologies, and constant vigilance. Today, I will divide my remarks into 3 sections.
Summarize the operational mandate and role of the CBSA in interdicting drugs at the border, including the importance of partnerships. Next, I will describe some of the technology we are using in identifying and seizing drugs. And finally, I'll speak directly to how we are dealing with the fentanyl issue. Mr. Chair, our operational mandate covers a range of pre, post, and at-border activities. We ensure public safety and national security through risk assessment and intelligence, and through coordinated responses to emergencies, threats, and emerging issues. Clearly, fentanyl and similar opioids fall in this category. These are the newest and latest substances appearing in our increasing volumes, most often found in our postal and courier stream. The most effective approach is to develop awareness of the threat and to mobilize a commanding response. Our National Targeting Center, which is a 24/7 facility, works to identify suspected high-risk people, goods, and conveyances through an integrated, comprehensive risk assessment program. Likewise, we deploy officers around the globe, pushing the border out to manage threats before they arrive at our doorstep. These measures demonstrate our capacity to look beyond the border to the point of origin for contraband and other threats. In addition to our in-house capacities, we are deeply integrated with our law enforcement partners across the spectrum, including the local police services, our provincial law enforcement, the RCMP, and our counterparts in the U.S. and other like-minded countries. The border is an obvious nexus for cooperative enforcement against drug trafficking and major crime. De plus, nous élaborons et cherchons sans cesse de
We are also constantly developing and researching innovative detection technology to assist our officers. There are a number of tools and systems in use at present. At the border, digital fingerprint machines allow us to quickly and securely transmit electronic fingerprint data to our partners in the RCMP.
Border and marine ports can determine the density of a surface or an object, and these meters can discover hidden walls and help us detect contraband. We also use flexible video probes and X-rays to locate undeclared currency and contraband, and fiber scopes to view areas of vehicles and cargo that are not visible to the naked eye. Various tools help us inspect the undercarriage of vehicles and other hard-to-reach areas. Trace detection technology is used to detect trace amounts of narcotics and explosives on sampled goods and conveyances. Finally, we are supported as well by a team of detector dogs that assist in the detection of illegal narcotics, firearms, and currency, which is further enhanced by the training we are giving our officers to identify threats and risks, and also supported by a world-recognized science and engineering laboratory. Mr. Chair, with respect to fentanyl in particular, we've seen an increase in the number of seizures since 2014. Fentanyl powder and equivalent substances are most often smuggled in Canada, mainly from China, as was stated by our RCMP colleagues, through the postal stream in our case. From January 1st, 2010 to September 22nd, 2016, the CBSA recorded over 115 fentanyl seizures. Due to the increased volume of packages sent through the postal and courier streams, it can be a challenge for the CBSA to identify and intercept all shipments of concern. Postal and courier shipments are often accompanied by false declarations or are intentionally mislabeled. La FCC prend au sérieux.
The CBSA takes its employees' health and safety very seriously. To that end, safe handling procedures and adequate control measures are in place, including personal protective equipment to prevent accidental exposures. Furthermore, given the pace of evolution with these products, the agency reviews their adequacy on an ongoing basis.
And our intelligence are important. The CBSA's collaborative efforts to address the fentanyl threat to public safety are ongoing at both the regional, national, and international levels. We leverage our intelligence and work with partners to identify and risk assess subjects and businesses who may be involved in fentanyl trafficking. We have a number of commercial risk assessment projects designed to intercept fentanyl and other controlled substances from air and marine cargo shipments arriving from China and Hong Kong. Our regional operations are participating in police agency projects, and our international network has been engaged with customs authorities in China on the fentanyl issue. La crise des opiacés est un défi qui nécessite des ressources.
The opiate crisis is a challenge that requires considerable resources and coordination. We have a responsibility to all Canadians to focus our efforts and strengthen our collaboration wherever possible.
Challenge. There are significant social, public health, and criminal justice impacts, and part of the solution lies in keeping the substance out of Canada to the greatest extent possible. And this is where the CBSA's responsibility lies, and we welcome the opportunity to discuss this further today. Merci.
Great. Thank you, Carolyn. And we'll move on finally to the Canadian Centre on Substance Abuse, Rita Notarandrea and Matthew Young. Rita.
Good morning, Mr. Chair and members of the committee. My name is Rita Notarandrea, and as was indicated, I'm CEO of the Canadian Centre on Substance Abuse. I'm joined today by my colleague, Matthew Young, a senior research and policy analyst at CCSA. Dr. Young leads our drug use epidemiology research, which includes the Canadian Community Epidemiology Network on Drug Use, or CENDU, the Student Drug Use Surveys, as well as work on novel psychoactive substances. I'd like to begin by thanking the committee members for inviting us here today. For those of you unfamiliar with CCSA, created in 1988, we are Canada's only agency with a legislated national mandate to reduce the harms of alcohol and other drugs on Canadian society. Today, I will touch very briefly on the crisis, given that others have already spoken to the prevalence and the devastation that individuals and families are experiencing in Canada. I will also mention CCSA's contributions to the federal response, and then based on our experience with this issue as well as with our partners, I would also like to highlight a few areas for action. Mr. Chair, as you are aware, in the past decade, the use of opioids and the associated harms have increased dramatically. In response, in 2012, CCSA brought together more than 40 dedicated experts and organizations to determine how best to tackle this national health problem. The diverse group, with ownership in both the problem and its solutions, included physicians, nurses, dentists, pharmacists, coroners, medical examiners, First Nations, law enforcement, researchers, and governments. We all recognize that this was a complex and multifaceted issue that could not be addressed by one level of government or one organization, as was stated. Everyone was tackling this in silos. In fact, there were at least 70 reports that were being looked at. We also knew that there was no one solution and that many of the intended benefits of these drugs in treating chronic pain also came with unintended harms, like addiction, overdose, and death. In 2013, 12 months later, the group released an ambitious 10-year national roadmap entitled First Do No Harm, responding to Canada's prescription drug crisis. This vision was reliant on efforts by everyone at the table, everyone sharing the responsibility of addressing the significant health crisis in our society. Designed to be comprehensive in its approach, the strategy included 58 recommendations for action in areas of prevention, education, treatment, enforcement, legislation and regulation, as well as monitoring and surveillance. Mr. Chair, in the past 3 years, we have made progress, and by we, I am referring to the collective we. My colleagues here today have highlighted some of this work. Other experts at that table also received funding related to recommendations in the report. Again, I repeat, a shared responsibility. I'd be happy to share copies of the initial strategy, the progress report, and an update of current activities by many of those partners. Mr. Chair, under the direction of Dr. Young, CCSA leads the Canadian Community Epidemiology Network on Drug Use, or as I mentioned earlier, CENDU. This nationwide network of community partners serves as an early warning system by investigating reported emerging issues, communicating alerts and bulletins on topics of immediate concern, and informing communities on lessons learned in responding to local drug use issues. CENDU first alerted its network to the sale of fentanyl in the illicit drug market in July of 2013 and followed up with alerts on fentanyl being disguised as OxyContin pills in February of 2014. I mention that because that is an example of unintended consequences of addressing the supply of prescription opioids and diversion, organized crime stepping in and producing and selling powdered fentanyl that was pressed into counterfeit pills or added to powders and sold in the illicit market, as was previously noted. In fact, giving increasing concerns about the harms associated with fentanyl from both illicit and pharmaceutical sources, and the lack of national data on deaths involving fentanyl, in August 2015, the CENDU network decided to collect and collate the number of deaths involving fentanyl from across Canada, spanning 2009 to 2014, to better understand this evolving situation and to plan for appropriate interventions as needed. Although use of any opioid can result in harm such as overdose or other health complications, illicit fentanyl and other new synthetic opioids pose an even greater health threat for a number of reasons, including the lack of regulation and quality control, as well as their potency relative to other opioids. People take these drugs believing them to be other, less toxic substances. And so, Mr. Chair, as I mentioned earlier, we knew that when we released the First Do No Harm, that this was a complex health and social issue, one that is part of a broader issue of substance use in Canada. We knew the strategy would require some refinements to keep it relevant and responsive as new information became available. We knew that priorities might shift. While the solution continues to be challenging, the positive news is that we don't have to start at square one. First Do No Harm provides a roadmap that speaks to prevention and professional education, treatment, monitoring, and surveillance, but it's all based on the evidence. We, and again, I mean the collective, we recognize the need for interventions aimed at reducing the supply of prescription and illicit opioids, as has been presented. These are important and should continue or be enhanced. We also recognize that we need to address demand and availability of appropriate interventions in a timely way. To that end, we recommend a few areas for attention, and these relate to evidence-based interventions, monitoring and surveillance data, public education and awareness, stigma, and collective efforts. First, the opioid crisis has shed light on the system of care for substance use disorders. We recommend increasing access to effective evidence-informed treatment services along the continuum of care. That includes primary care, treatment services, and supports. We need to ensure that treatment is available. We need to ensure that these services are based on the evidence so that people seeking help get the help they need and the support they need. We need to promote accreditation and licensing of facilities providing treatment and the required qualifications of the health professionals. Every door open should lead to help in getting the needed treatment and supports from those with the competencies, the current knowledge and skills to provide those supports. Yet sadly, we have heard in the news of facilities, many privately funded, providing health services to those with an addiction problem, lacking in qualified staff, and in fact giving wrong information to clients. We have discovered through the opioid crisis what needed to be added to the health system to properly respond, to effectively treat those with an addiction to opioids. We learned that primary care professionals were not well equipped with competencies in pain management and addiction, that the curricula did not effectively address these areas. Therefore, we need to provide education and resources to help primary care professionals, as an example, to prescribe according to guidelines, to identify and intervene early. As we deal with the crisis, we know that many are looking for evidence-informed services to meet the needs of those with an addiction to opioids. As has been mentioned, interventions such as naloxone, overdose education, opioid substitution therapy, supervised consumption sites, or effective medications like Vivitrol that are unfortunately not yet available in Canada. And as I continue to refer to the evidence in addressing the opioid crisis and treating those who need support with effective interventions, I'd like to draw your attention to a new report by WHO, the World Health Organization, and the United Nations Office of Drugs and Crime entitled International Standards for the Treatment of Drug Use Disorders. It speaks to the continuum of care, different interventions along with the strength of the research supporting these interventions. Mr. Chair, we would be pleased to send copies of this report to the committee clerk. Second, in order to address what is happening across the country and the impact of our actions, we need a comprehensive national monitoring and surveillance system, the national picture. In many countries, this work is undertaken by a National Drug Observatory or an NDO. As was mentioned, just yesterday, Health Canada, CCSA, and the Canadian Institutes for Health Research hosted a Best Brains exchange to examine possible models for establishing a Canadian observatory and to assess how these models could support general and targeted drug surveillance. But this also includes, in each province, prescription monitoring programs. CCSA will be meeting with Health Canada and other leaders in this area to explore how best to develop this Canadian Drug Observatory in Canada and an early warning system. Given the enormous amount of work that is required to develop a Canadian National Drug Observatory, as well as the strengths of many national leaders that are working in this area, such as Health Canada, CCSA, CIHI, the key to successful establishment of a Canadian observatory will be a clear vision, an understanding of the roles and responsibilities of leaders in this area, as well as the jurisdictions, and a delineation of what is needed over the short and medium term to identify emerging issues and respond quickly. We do this well when it comes to physical health and infectious diseases, as an example. Third, Canadians need access to accurate information to make informed decisions about their health. We need to do a better job at informing and educating Canadians about opioid-related harms and how to share in the decision-making when seeing their health professionals. Canadians also need to know about evidence-informed, non-pharmacological treatments for pain and about quality accredited treatment services for their substance use disorders. And they need to know the symptoms of overdose. They need to understand the importance of the safe storage and disposal of their unused medication and of the dangers of driving while impaired by opioids. And finally, Mr. Chair, one of the biggest challenges we face in addressing this crisis is societal stigma. Many still believe that addiction is a moral weakness. This means that people have to pay to get timely access to treatment, and when they do, this does not guarantee that the facility will provide quality care and treatment. We need to elevate awareness about the science that surrounds these disorders. Mr. Chair, I look forward to continuing to work with our partners to bring about the needed changes to help address the opioid crisis and the devastation on people's lives. We look forward to collaborating with Health Canada, particularly on the opioid conference and summit that is coming up in November. There will be opportunities to connect with the First Do No Harm partners in addressing this issue and in developing concrete actions. CCSA will continue to coordinate collective efforts, connect partners, gather and share evidence, identify emerging issues, and address stakeholder needs as per our mandate. Dr. Young and I would be pleased to answer any questions you may have at this time. Thank you very much.
Thank you very much, Rita. And yes, please, if we can get copies of the reports, please bring it to the clerk. Would be much appreciated. All right, let's move on to our round one of questioning here. I've got Mr. Randeep Surya, are you up first then, are you? Yeah. Sure. You've got 7 minutes, Mr. Surya.
Thank you. Thank you all to all the panelists. I'm very delighted that all of you have a very attentive knowledge on fentanyl. As you, and this question is to the RCMP, the RCMP division headquarters are in my riding of Surrey Centre. Some of the country's best and brightest law enforcement professionals live right in Surrey and across the Lower Mainland. I'd like to know what sort of strategy the RCMP has in place to address the crisis, given the negative impact it's had in our community.
Thank you for your question. The RCMP has a number of strategies involved. We have a number of years ago, the RCMP instituted what we called a synthetic drug strategy that focused on the prevention, the enforcement, and of course education. Also, within the ranks of the RCMP here at Ottawa, as I shared within my opening remarks, we have liaison officers and then analysts that are posted around the world, as many of my counterparts here at the table shared with you today, to build those relationships we need around the world. Because as was shared with the committee, a lot of the fentanyl that we're looking at is coming into the country. So how do we build those relationships with those particular countries to be able to address it at source and prevent some of those issues, some of those products from entering the Canadian market? I was just recently, last week, spoke at a Canada-U.S. border symposium. It was addressed by the administrator of the DEA. Mr. Rosenberg was there, and the issue that he raised as well was the issue of fentanyl and the emergence of W18 or carfentanil, as well as what they're seeing in the U.S. and the significance that they're placing on the prevention efforts and the education efforts within the U.S. and how to reach the youth at risk. And he stated within that is what he sees as significance is the partnerships and the collaboration between the Royal Canadian Mounted Police and the American authorities in securing our borders as we work along with our border enforcement officers who are also CBSA counterparts who are also there. As I shared as well, through our office with Monsieur Chicon here and our Federal Coordination Center, we've done a lot of work with our communities, video, printed products, our frontline officers, adjusted our policies, the issuance of naloxone to our frontline officers, and collaboration throughout the spectrum of government departments and consultations to inform from an enforcement perspective what the RCMP can bring to the table. Because I think, as we've heard today from all the counterparts here, it's a collaborative effort amongst a number of departments. So there's a number of things, from the international to the domestic, to our frontline officers, and to being part of the team that's before you here to inform each other to advance a Canadian effort against this crisis.
Along that same lines, is there any support that you think in our criminal code or otherwise that would be helpful to help you prevent this or enforce this? Is there anything you think that our criminal code or perhaps our legal streams are lacking?
I think my approach to this has always been, we can always look at other areas and say they have this or that. My approach has been is the as the bodies within Canada that decide what the laws within Canada will be, and we are there to enforce those laws. If laws are being considered and our opinion is asked, we will certainly inform those discussions, but at present, we work within what the Criminal Code of Canada provides us today.
Thank you. This one is to the Canadian Centre of Substance Abuse. As you may well know, Surrey has been hard by the opioid crisis, along with other areas in British Columbia and Alberta, particularly by fentanyl-laced recreational drugs. My colleague Sue Dhaliwal held an emergency summit with health professionals who work with individuals on the street that have substance abuse issues. Through these dialogues, I've heard conflicting conclusions as to whether or not opioid prescriptions should be reduced. I'm curious if you can disclose what your research indicates on this matter. So some have stated that the prescription should not stop, that some of the opioid-based prescriptions are helpful in reducing addictions, and otherwise the alternative is fentanyl-laced drugs. And others have said that the prescription-based opioid use is very high. What's your opinion on that?
I think I do want to stress one thing, that when we first did First Do No Harm, there was an impression that there was one solution to the issue. And I think, as all of us have said, there is no one magic bullet, no one solution. I think we do need to address prescriber education. I think we need to look at ensuring that clinical practice guidelines are being utilized in the physician's offices by primary care professionals. At the same time, we also need to look at diversion. And we need to ensure, first of all, that the physicians are complying with those guidelines. And we do have evidence that indicates as to what those guidelines ought to be, and where do the physicians that are prescribing we need to look at then what physicians are prescribing higher than those guidelines. And when I mentioned prescription monitoring programs, I was referring to that. As to the diversion, there is a lot of diversion right now, and I think that was mentioned, and we're seeing that. So it isn't one answer to the problem. It is, we have to look at both.
Thank you. I'll give the rest of my time to MP Sonia Sidhu.
Okay, you've got 1 minute then, Ms. Sidhu. Thank you.
Thank you, all the witnesses, sharing your valuable information with us. I would like to start by discussing safe injection site. Recently, we have seen many media articles and municipalities thinking about making safe injection sites to help reduce overdoses and address addiction problems. What does the current evidence say about positive impacts of safe injection sites?
Thank you very much for the question. The evidence is overwhelmingly clear that when a supervised consumption site is properly established and properly maintained, it saves lives without increasing rates of crime in the surrounding area. There have been numerous studies, both domestic and internationally, that point to that, and there is a relatively long history of experience with supervised consumption sites in Europe upon which to draw, and over a decade now of experience with Insight in Vancouver that all point to that fact.
Great. We'll have to move on. Your minute is up now. I'm sorry. We're moving on to Dr. Colin Carey next for 7 minutes.
Thank you very much, Mr. Chair, and I want to thank the witnesses for being here today, because this is a serious crisis. And I think maybe I'd like to start off with Dr. Sharma, because you are a physician. I think we all realize that addiction is a treatable condition, and that's why our government, our approach was basically, we had our anti-drug strategy, put $500 million out there to keep drugs out of the hands of addicts, looking towards prevention and treatment. And I think at that time, the mandate from Health Canada was basically they really wanted to look after the health and safety of Canadians. And I think that's still true, isn't it? And I think it's really important with this situation we're facing that Health Canada and the Minister's Office is really open and transparent. But there has been some worry about some of the Minister's actions and judgments and some of the controversial decisions that she's made. So I was going to ask you about that. With the seriousness of opioids on the street, If there are reports going back about contaminated or adulterated drugs on the street, I think it's very important. And we heard from the media, unfortunately, that Tilray, a company, I believe, in British Columbia, sent information to Health Canada that there was in dispensaries marijuana that was adulterated with carcinogens, fungicides, and pesticides. And the minister chose not to let Canadians know about it. And as the senior medical advisor for health products and food branch, if information came across your desk in regards to an adulterated opioid that was on the street, do you think it would be important to get that information out to Canadians, whether it's a press release or something along those lines or through the media, so that Canadians that may be using these substances would know about it? Do you think that would help in the health and safety, protecting the health and safety of Canadians?
Thank you very much for the question. So in terms of the authorizations in Canada for opioids, they're marketed products. And so if there was a situation where there was an adulteration or contamination, we would embark upon an assessment to see what the risks associated with that would be, and then look at whether or not there were compliance enforcement actions that we would need to take. And there's a whole suite of compliance and enforcement actions that we can take, all the way to recalling the product, changing labels, etc. But in the case of
off the street, and you could do something about it, let Canadians know about it, and not wait a year, right? You wouldn't do that, would you?
So the decision in terms of a risk communication, then, once you know what the risk is and once you know what the action is, then we make a decision about what the most appropriate form of communication is. And again, that can be putting something out on the web, it can be a news release. It really depends on a case-by-case basis on what the risks are and what the assessment would lead to.
So all I'm saying is waiting a year to get that information out, having to find out through the media, I just think that's a poor judgment. Maybe I'll start another question for Madame Geller. You do know about the Salome study?
Yes.
And with that study, did it find that hydromorphone was a valid alternative to actual heroin and have less risk?
Right. Perhaps I can take that. So Salome was a study to assess long-term medication opioid use, and the aim of the study was to do, just as you had said, is to compare the use of injectable pharmaceutical-grade heroin or diacetylmorphine with the use of hydromorphone, which is an injectable form of a pain medication that's approved in Canada but not approved for the use in opioid addiction at this point in time. And the results of that study did show that in the study population that hydromorphone was equally as effective as pharmaceutical-grade heroin, and it did show some advantages in terms of adverse events as well. But that's one study, and obviously that has to be taken into the context of the body of scientific and medical literature that's there.
Well, I think it's promising. And when I heard that the minister, and I think Madame Geller mentioned with the special access program that really was developed for patients had serious or life-threatening conditions when conventional therapies have failed or unsuitable or unavailable, that the special access program actually is being used to get the pharmaceutical heroin out there. It was never really intended for that. And when you would have a legal alternative to it, even in the access statement here on your website, don't you think that we should be trying to substitute a legal, safer alternative than to actually get more heroin out on the streets?
So the special access program is, as you had said, is intended for emergency and life-threatening conditions. An individual physician comes in and makes a request for an individual patient, and it's assessed as such. So when requests come in, we do look at the information that the physician has provided. There's assurances that the physician has spoken to the patient about the potential risks and benefits, and then they're assessed on a case-by-case basis. So when comparing the two products, hydromorphone is a marketed product, but it is not marketed for that use. And diacetylmorphine has also a body of evidence that supports its use in terms of chronic relapsing opioid dependence, and it's been used in a number of different countries. So as with any request through the Special Access Program, we would look at that individual's information and the request that's being made to make sure that it fulfills the criteria of the Special Access Program and it's reasonable. And in some cases, you're right, we have authorized the use of diacetylmorphine. In many cases, it's when it has to be when all other treatments that could be applied have unfortunately failed. So it's a very small percentage of patients.
Yeah, hopefully, and it stays small, because I know that program, I've actually advocated and tried to help patients who have life-threatening cancers. I know that program has this limited number of funds, and to see that those resources go towards access to heroin when there is a legal, safe alternative out there that may be available in another way, I just feel that maybe we need to keep a close eye on that. Maybe the third question, Dr. Young, the SENDU reports you have are extremely valuable to us, and I want to thank you for that. A few years ago in Ontario, Deb Matthews, who was the health minister, basically demanded and begged that the federal government move towards tamper-resistant opioids.
Dr. Perry?
Yeah.
I'm sorry, but your time is up. Perhaps next time around you can continue on with that, but I'll have to move on now to Mr. Davies. You've got 7 minutes.
Thank you, Mr. Chairman, and thank you to all for being here today. 800 British Columbians are expected to die from opioid overdoses by the end of the year. That's 1 by noon today, 1 by midnight. Dr. Perry Kendall, the Chief Medical Officer of British Columbia, has declared a public health emergency in British Columbia. Hundreds more will die in Alberta, and about the same number are expected to die in Ontario as in British Columbia by the end of this year. 2,000 Canadians are expected to die from overdoses across our country this year. That's a Canadian dying about every 4 hours. The RCMP reports that the fentanyl market is expected to grow in the next 18 months, which means that even more Canadians will die. 2 grains of fentanyl, the size of a salt crystal, 1 grain in the case of carfentanil, are capable of killing drug users, including young people who don't even know they're ingesting it. This puts our first responders and our police at risk. These are our neighbors, our friends, our families dying. As Ms. Geller said, no one is immune. So my question, Ms. Geller, to you is this: is the national opioid overdose crisis a national public health emergency?
Certainly BC has declared it a public health emergency in BC. If you look at the definition of an epidemic, as set out by the World Health Organization, it has to do with levels of death or disease above an average level. So by that definition, certainly in British Columbia, as declared by the government, it is indeed an emergency. If you go with that strict definition, I can honestly say, because unfortunately with some of the data limitations, I think it's impossible to tell you if that definition would be met in every other province, but certainly we see growth in Alberta, as you said, and signs that is moving eastward. We've heard from police in Ontario indicating that. But I think from our point of view, we are treating it as an emergency to help jurisdictions across the country have what they need in order to be able to respond, and so that we as the federal health department are putting everything in place within our areas of authority and encouraging others to do the same, so that not only can we respond in BC, but we're ready for when it emerges elsewhere.
Okay, I don't mean to interrupt, I have limited time though, but doesn't the Public Health Agency of Canada have the ability to actually declare a national public health emergency?
I apologize, I'm not familiar with their legislation.
Okay, thank you. Now, we've talked about Bill C-2. Every stakeholder I've talked to in the country, including Ms. Geller, you've crisply described the evidence. We know that safe consumption sites save lives. We also know from every stakeholder in the country that Bill C-2 that was passed by the previous government establishes 26 separate discrete requirements that every group I've talked to in the country says establishes unnecessary barriers to establishing safe consumption sites. It takes months, hundreds of hours, and I've talked to the Toronto Board of Health, I've talked to the City of Montreal, I've talked to the City of Victoria. These are not fly-by-night operators that want to open safe consumption sites. These are the municipalities and boards of health in our provinces that are telling us that safe consumption sites save lives, and this legislation puts up unnecessary barriers. Now, Ms. Geller, you said that your strategy is to explain the barriers to the groups, but they're not. These groups aren't telling me that they need the barriers explained to them. They're telling me that they need the barriers removed. So my question is actually to Ms. Notarandria. Does your group support the repeal or the streamlining of Bill C-2 so that we can get more safe consumption sites up and running and save lives?
Our group is really an organization that looks at the evidence, and I think Ms. Geller has spoken to the evidence of consumption sites. But we also look at ensuring that the public is protected. And so I think there's always a balance. And right now, in terms of the bill, and what I have been told is that it's being facilitated. People that are putting forth proposals are being given a lot of assistance in ensuring that those proposals are successful.
So you're happy with the state of affairs in C2? Is that the position of your organization?
Again, the position, we don't have a position per se. What we say is, what does the evidence say about consumption sites? What does it say in terms of being part of a continuum of care? And we support that it be part of the continuum of care. What we have been told is that every effort is being taken to ensure that the public is protected, as well as those individuals that are suffering are protected.
Okay. Mr. Sheen, Dr. Jane Buxton, professor at the University of British Columbia, recently told this committee that about 82% of people in Vancouver call 911 during overdose events, but that number falls to less than 60% in regions outside Vancouver, primarily where the RCMP is the police force. Dr. Buxton attributed this in large part to the VPD's policy of non-attendance at 911 calls for overdoses. Has the RCMP explored such a policy?
I'm not aware that the RCMP has looked at such a policy.
Thank you. Ms. Xavier, when BC's Premier started a task force on fentanyl in late July, she called on CBSA to search small packages for fentanyl. But Clayton Pecknold, BC's Director of Police Services and co-chair of the task force, has been clear that this policy has not been implemented. He says we're still waiting for the Federal Minister of Public Safety to get back to us. We've asked very explicitly for new strategies to interdict fentanyl at the borders and to give the CBSA the tools they need. On September 15th, the CBSA said that they're looking at new ways to screen mail, but so far hasn't changed its policy. In the case of suspicious packages under 30 grams, they currently contact the importer to request permission to open the mail, and if permission is denied, the mail is returned to the exporter. In your view, why has the CBSA not responded to the task force's request to search small packages?
So, with regards to
I
the
will have to
limitations in
interrupt
our...
here. I'm sorry. Your time is up, and you'll have to wait until the next time around, Mr. Davies. I have to move on to Dr. Ailson. You're next. 7 minutes.
Okay. Thank you, Mr. Chair. Thank you all for coming. This is something that's been near and dear to my heart. I practiced emergency medicine for 20 years, much of it in the inner city of section of Winnipeg. And we've seen many of these problems firsthand. Now, Ms. Geller, we talked about, Mr. Davies was talking about C2 and the restrictions that it, there were some restrictions that it placed on safe consumption sites. In your view, has this bill, has it impeded your ability to monitor the crisis by slowing down the development of safe consumption sites in cities?
Thank you for the question. I think it's important to recall that before the amendments to the CDSA, the Controlled Drugs and Substances Act, known as Bill C-2, Bill C-2 was not a standalone piece of legislation. It was a series of amendments to an act. There were a set of published and rigorous criteria that potential applicants had to fulfill. So with or without a piece of legislation, there would inevitably need to be some strict guidelines so that the decision maker had all the information he or she needed in order to make an informed decision and to ensure that if it was to be established, it would be properly run and properly maintained. I think it's also interesting to note that most of the criteria, the 26 application criteria that are in the CDSA, are very, very similar to a guidance document issued both by the British Columbia government and the Quebec government, which were designed to inform people in their provinces about the types of information that they should be prepared to provide if they were considering opening a supervised consumption site. So what I will say is there's certainly a tremendous amount of interest out there in opening new facilities. Staff in my department have regular very detailed conversations with those potential applicants. And what I am told is that in general, after having had those levels of engagement, that the general view is, thank you very much. You've really helped clarify what is needed. You've helped me understand how this sort of information was provided by others, in particular Insight. And we now know what we need to do in order to be able to submit a proper application.
Okay, thank you. Thank you. Now, there's been a bit of a change in philosophy over harm reduction, safe consumption sites. We do know that previously there was a lot of opposition to it. There was Vancouver was the only site for a long time, simply because the status was unknown. It was being appealed to the Supreme Court. We didn't know if it was going to exist anymore. If there had been a less objection or less resistance to harm reduction throughout the past few years, would that have made it easier for surveillance and treatment and to get ahead of this problem earlier with the crisis?
I guess surveillance and treatment are two different things. I will say on the surveillance side, and it's no secret that we and colleagues here refer to it, we don't have a terrific system of surveillance at a national level. And the development of surveillance systems, I think, is variable across the country. Places like BC, it's excellent. Other places, not quite there. So that is something that we're working on. So that's what I would say on surveillance. On treatment, I think it's always been recognized that treatment is incredibly important. There was a significant investment into treatment in the 2014 budget, coming out of the work of this committee and the work that Rita had referred to earlier on First Do No Harm. And there is certainly more that can be done, both in terms of work on medication-assisted therapy, but also treatment indicators, work on First Nations, and I'd say that is continuing to be a focus of ours.
Mm-hmm. All right, thank you. Thank you. My questions. Next question for colleagues from the RCMP. Thank you for coming. I particularly like seeing you here, being an RCMP brat myself. Mm-hmm. Now, there have been different philosophies on drugs, and from the legislative and sometimes law enforcement, the part of the, and I quote, tough on crime approach and the zero tolerance approach. There are others who have said that this zero tolerance, tough on crime approach has sometimes made things worse in driving people underground to not seek treatment. What would your views on that be? Do you think that primarily criminalizing these activities is making things worse by driving it underground?
Thank you for your question. Being an RCMP brat, and my son just completing his second-year residency, wanted to be an emergency room doctor. I think we have something in common. I guess what I'd like to share is that from a law enforcement perspective, when asked, we will inform discussions around any legislation, and our role is to enforce the legislation that our government puts forward, and that's essentially where we stand with that. We're asked as new legislation comes forward, and we will certainly provide input if requested, and then our role is to enforce the laws that our parliamentarians have decided is the law of the land.
Mm-hmm. Yeah. Have you found from the law enforcement point of view that, I mean, we only have one in Canada now. Have the Has law enforcement in the BC area seen any increase in crime due to the safe consumption site?
I'm not aware, and I know I've asked. I'm not aware that we've done a specific study around an increase with regards to a crime increased around a supervised site. So I wouldn't be able to give you an answer other than not that I'm aware of any particular study being done on that regard from an RCMP perspective.
All right, thank you. I think I have about 15 seconds. Is that right?
15 seconds, yes.
So there's probably not enough for another question. So thank you very much.
Great, thank you. All right, we're going to our second round now with 5-minute questioning, and we'll start with Rachel Harder.
All right. Thank you very much. Okay. Well, I guess my first question, sorry, I can't see names, but it would go here to the Canadian Centre on Substance Abuse. I apologize. You talked about a little bit about needing to strike a balance between the safety of the public and then, of course, wanting to pursue some sort of safe injection venue, let's say, for those who use drugs. So with regards to finding that balance, what would you say with regards to the protection of the general public? What are some of the challenges that are posed with regards to general safety for the public?
I think, if you don't mind me saying, when I talk about treatment, we've been focusing on safe injection sites, safe consumption sites. There is an array of treatment options. And I do want to say that when I talked about those standards from WHO and UNODC, there are a variety of treatment options for the treatment of substance use disorders. And I do want to say that we need to look at interventions that are based on the evidence. So those are all the options available for people that are suffering from substance use disorders. And as part of that bigger bucket of substance use disorder, there are those that are suffering from an addiction to opioids. So what I'm saying is we need to look at all options to effectively treat the individual when they present with all of the complications that come with addiction. So we have to have a comprehensive approach. We have to help them in terms of their disorder, and we have to meet them where they are and keep them safe as well.
And as a part of this comprehensive approach, then, I guess one of the questions that I have, if you're going to have a comprehensive approach, it seems that it would then be appropriate to perhaps have a prevention mechanism in place. That should be a part of that comprehensive approach. But then also, what about getting people off of addictive behaviors? What about getting them out of addiction? Is that a part of this comprehensive approach? And what would that look like?
Absolutely, it is. And that comprehensive approach, when I spoke to the First Do No Harm, did speak to all of that comprehensive approach. It did speak to prevention. It talked about consumer education, public awareness, how to have that conversation with your physician, how to speak about other options besides opioids in terms of pain management. So that is one of them. The other part of that is the physicians themselves, primary care. I did mention in my remarks about primary care not having the competencies as they have reported in terms of pain management and in treating and recognizing addiction. Also the whole treatment continuum. So I talked about prevention, education. Now in terms of that treatment continuum, what does that treatment continuum entail? Do we have all the evidence to support the treatment that is out there? Because some, as I mentioned earlier, some residential treatment facilities, and I think in BC there was an interesting article that spoke to 150 residential facilities and some of the information that they were providing to desperate families that were looking for care for their loved ones. So the evidence is there. I think we have to ensure that that evidence is applied all the way in that continuum, from prevention, from education, from treatment, and in recovery.
And in your estimation, what are some of the best treatments? What would evidence show us? What should we be pursuing with regards to treatment?
It's very comprehensive, and that's why I indicated I'd be more than happy to share that report, and it speaks to the latest evidence, and it speaks to the strength of the evidence along that continuum, including the prescribing of opioids.
Okay. And at the end of the day, if you had to prescribe the root cause of this opioid crisis that we're seeing in Canada today, what would you estimate that to be?
I'm sorry to say that I don't think there is one cause. And I do think it's all the things that you touched on. It is about prevention. It is about prescriber education. It is the whole continuum. It is about enforcement and what more can be done there. It is about the public knowing that you don't have 40 opioids sitting in your cabinet, because 3/4 of the students did say that they were getting their opioids from home. So I believe it is a comprehensive approach, as has been stated. There is no one solution.
Thank you.
Great. Thank you. Time is up, Ms. Harder. I'm going to move on to Mr. Kang Arshan.
Thank you, Mr. Chair, and I want to thank all the witnesses to come up here before the committee to address this very, very serious issue. And I know in Alberta too, we are going through a tough time. It's very serious in Alberta, and I wish we get some direction from the committee to have come to some kind of resolution on this issue sooner the better. But I would like to pass my time on to Ms. Sidhu so she could ask the question on this. Thank you.
Okay, if you could also clarify briefly the previous government regarding safe injection sites. Is C2 a stand-alone bill that can be amended?
No, Bill C2 were a series of amendments to the Controlled Drugs and Substances Act.
We have seen comments from some people saying the current process for applying to safe injection sites is too difficult or obstructive. I recall most recently seeing the Mayor of Vancouver talk about this. I know the Minister has said that there should be a review of the legislation. What can you tell me on the status of that review? What areas of the legislation could be improved if there is?
That review is ongoing, so I think it's premature to say that there have been any conclusions drawn yet. But what we are doing is we are assessing the bill, the CDSA portions that relate to the specific provisions on applying for a supervised consumption site against the experiences that we're having now. We've now had, over a period of many months, numerous discussions with potential applicants. There is actually currently only one applicant who has submitted, and that is well known, that is Montreal. So obviously we have the most experience with Montreal because they are furthest along. But we are trying to have very, very detailed conversations with them to understand whether there are any specific criteria that are problematic for them. If perhaps it's just more of an issue around not really understanding what's required. As I think I mentioned earlier, they are finding it very useful, particularly when we can very accurately describe for them in the context of Insights application precisely the type of information that it is that they need to submit. So it's in that context of the real lived experience that we now have over the last year, and analyzing it against the legislation that's going to give us the ability to make some recommendations to the Minister in due course.
Thank you. And so you said just one application are currently processed. Okay, thank you. And particularly, I noticed how the discussion was headed to direction of CDSA and the Minister's comments recently regarding it. And I would like to understand the overdose addiction problem impact both on addicts, and if there are and broader community effects we should be aware of. Is there any, and this question is to Rita Notrendra. Is there any broader communities there's this impact both on addicts or any broader communities who are affected mostly?
If I understand correctly, different populations that have been affected?
Yes.
Certainly, and Matthew has some more recent information. The populations that we are seeing is the older adults, in some of the work on utilization. We are seeing the youth, First Nations communities. So those are the populations right now that are demonstrating greater increases in terms of not just opioids, but also women and benzos, as an example. So when we look at the different prescription drugs, I know we're dealing with opioids, but certainly when it comes to women, it has to do more with the benzos. So there are a different population and there are different issues, and utilization is certainly showing increases, as I mentioned, in two key areas, and that is the older adult and youth. But I did want to stress that First Nations as well.
Okay. And I'll pass my time to Ron.
Thanks, Mr. McKinnon.
Well, thank you. Welcome. Welcome. Nice to hear from on your testimony. I'd like to thank Don for his cue to me to mention that this committee was expeditious in its study of my Good Samaritan Drug Overdose Act, which will hopefully facilitate the allowing people to be less concerned about calling the police. And since I have no more time, I'll leave it at that. Thank you.
Sorry about that, Mr. McKinnon. We'll move back to the Conservative. Dr. Carey, is it, or Ms. Harder?
I'll do it, yeah.
Okay, Dr. Carey, you got 5 minutes.
Thank you, Mr. Chair. Yeah, I just wanted to point out there seems to be, the Liberals seem to be really focusing on safe injection sites, and the truth is they're only putting resources into that. In the budget, there was no new money for treatment, there was no new money for prevention, and there's no new money for education. And one of the frustrations I have is that in Oshawa, if a addict wants treatment, he has to wait. And sometimes he waits weeks and weeks and weeks, and then he relapses before he even gets the treatment. So it would be easier for him just to go to a place and keep injecting and injecting and injecting. And I just don't think, unless you put the priority on treatment, that we're going in the right direction. It was interesting to see the minister's priority. I think the treatment was number 3, but I like what the Center of Substance Abuse, you said treatment is number 1 because this whole obsession with safe injection sites. C2 doesn't stop safe injection sites. It lets people who have the right to know and get input, because if the community doesn't support the injection site, it's not going to be successful. But anyway, I want to get back to my question with Dr. Young. Our government was moving in step with other people around the world. I know we got letters from governors of the United States, the White House, to look at this entire class of drugs, move them towards tamper resistance or abuse deterrent formulations. That was where we were going. And this past June, Minister Philpott at a Toronto drug policy conference said that the introduction of tamper-resistant form of OxyContin in Canada essentially caused or was strongly anecdotal evidence of causing the current fentanyl crisis in Canada. I just wondered, is this true, or is the situation actually more nuanced and complex than that?
Well, thank you for your question. So one of the things that we've seen for quite some time is that there are a lot of interventions that have been put into place that will ideally, and if effective, will decrease this demand for opioids in the long term. But one of the immediate impacts that they've had is decreasing the supply. And I think that probably abuse deterrent formulations fit into one of those. And one of the things, when you have a supply that is in excess of the demand, you have what we see now, organized crime stepping in and filling a market. So I don't think that directly answers your question, but that's kind of the landscape that we're in right now.
Well, I know that we're in that landscape now, but it seems that it would make sense to me, even the proof in the pudding, once OxyContin was made tamper-resistant, people couldn't use it, or it was much more difficult to use it. So if you had a strategy to actually make the entire classification of drugs, if they're available, to make them tamper-resistant, that should actually slow down the access of diverted OxyContin or similar type of opioids. So it just doesn't make sense to me. Isn't it true that generic OxyContin was and still is available in Canada after 2012, and that provincial regulatory colleges started to advise of shorter prescription lengths and lower opioid dosages in 2012? Because those who are suffering from addiction, don't they just chase the next drug that's around there? Like by moving away from tamper resistance, when that technology is out there, it just doesn't not make sense to actually utilize the technologies that are out there when you're looking at an overall strategy towards opioid abuse?
I'll answer your question. So in about 2014, we became aware of organized crime taking fentanyl and putting it into counterfeit oxycodone tablets. So I don't know a lot of the answers to your specific question, whether that intervention was the key one that should have been done or should not have been done. I just know that in around that time, there was a market for that was satisfied by organized crime with counterfeit oxycodone tablets. So presumably that was because there was decreased supply of diverted pharmaceutical opioids into the illicit marketplace.
But I think one of the challenges now, having generics out there so readily available, I think we have heard the governors of northern states, I think, have written to the Minister of Health. I was wondering if we could ask Border Services, are we starting to see this generic OxyContin going back and forth, and is it causing problems at the border with the northern governors? Are they getting a little upset about this?
I can't speak specifically to whether it's specific to OxyContin. I'd have to get back to you specifically if that's what you're looking for. What I can tell you is, as I mentioned in my opening remarks, that we are seeing increased contrabands trying to make their way through, for example, a courier and a postal stream specifically. And so as was mentioned by our CMP colleagues, contraband management continues to be something we're dealing with in the greater organized crime activities.
Okay, thank you. Your time is up, Dr. Carey. Going to have to move on to Mr. John Oliver.
Thank you very much. Good, thank you. Thank you for your presentations. I wanted to focus on changing behaviors of the people who are illicitly seeking fentanyl and opioids. Seems to me there's three categories. There's the sort of recreational, experimental users. I'm thinking young adults, teenagers. There are people with substance use disorders, mental health and addictions. And then there's a third category of what I would call the unintended addictions from pain management. So Mr. Diverty, or perhaps Dr. Sharma, have you done the analysis? I would think there's different strategies to deal with those three sort of populations. Have you done the analysis? What's the percentage? How does that break out?
Thank you for your question. We've actually got a study coming out in about a month that looks at hospitalizations due to opioids. And one of the things that we're seeing in that study is, in fact, that seniors and young people do have a different profile when it comes to the reason for the hospitalization. I'm talking about acute hospitalizations in this.
5 minutes. If you just get to the punch of the answer.
Sure. Okay. So in the senior population, you do see more of the sort of accidental and unintended opioid poisonings. In younger people, they're more of the intentional.
Is that like 80%, or is it one-third, one-third, one-third? How would you see the distribution of this?
We're still finalizing the numbers for this study, but I think that's why I just can give you the overall trend at this point.
Okay. So right now you don't know. Okay. So then, Dr. Sharma, would there be different strategies? I mean, if you knew the majority were people that had unintended addictions and were now seeking them, would you have different strategies for that? And I'll come back to Big Pharma. So Purdue, I think, has moved over to hydromorph-contin. They're still wrestling with getting that into a non-tamper-proof form. All provinces are using it now, have agreed to use it, except I think for BC. So what's the role of Big Pharma in educating doctors on prescriptions, and are we monitoring doctors' prescription writing habits like we do with narcotics?
So I'll take the first part of the question. If we have clear information on what the risks are, then you can have appropriate strategies. And you're correct that for different circumstances there would be different strategies. The situation in Canada is more complicated than that because people may enter into a situation around use of opioids from one channel, but then it may be fluid, so that you might be moving from one place to another. And over the course of a single patient, that might change as well. So I think that's why we're talking talking about a multi-pronged, comprehensive strategy so that we're actually being able to address various different factors simultaneously. In terms of the role of the pharmaceutical companies, certainly they're the ones that are manufacturing the products, marketing the products, and are partly responsible for the way that those are used. But there's also, obviously the role of the pharmacist, the role of the physicians and the practitioners, and so that's why you have to address it from a very much, as I said, a comprehensive strategy.
Okay, great. So there are strategies underway to influence prescription writings. It seems like this is an increasing problem. Unintended addictions are still occurring. Have you seen any breakthrough strategies that will stop that particular group of people from falling into this behavior?
Well, from the Health Canada perspective, because we're the ones that actually authorize the medications, our goal is to make sure that people have accurate and adequate information to be able to make those decisions. And, I came from when I went through medical school, we were very trepidatious about the use of opioids. I think there was a change in terms of the use, and we're trying to recenter the pendulum. So one is making sure that there's appropriate information that's available, and as well, Health Canada is actually working with the DeGroote Centre for Pain to provide guidance and guidance documents for practitioners to be able to use the medications appropriately.
Okay, thank you. And my last question is to Ms. Geller. Ms. Geller, so for young kids, I don't know what the percentage of they are that are experimenting and overdoses and hospitalization are occurring. It'd be good to see the outcome of the study from CIHI. But what are we doing to be at the school level, at public health, to talk about the dangers of fentanyl and the dangers of using these, the stamp green drugs that could potentially kill, an 18-year-old partying experimenting at a party?
Thank you for the question. So the problem with the younger people, not exclusively, but in general, tends to be more about using prescription medication that they find in their parents' medicine cabinets recreationally. And surveys show that somewhere between 2% and 4% of young people use prescription medication recreationally in that way. And there has been a campaign run by Health Canada over the last number of years that's designed to get at that problem. And that work will continue. And as part of the Minister's 5-point plan, she's also undertaken to ensure that international best practices on prevention. It has been proven that the scare tactics, the just say no to drugs approach doesn't work. The approaches that do work are much more about building resiliency in very young children, and that is part of our plan.
Great, thank you. We'll have to move on now to Mr. Don Davies. 3 minutes.
Thank you. Ms. Javier, I'll give you a chance to answer that question I asked you, which was why has the CBSA not responded to the BC Task Force's request to search small packages for fentanyl?
So the Customs Act Section 99, subsection 2 stipulates that the CBSA is not able to open packages under 30 grams. And as a result, we wouldn't be able to open those packages, or else we'd be breaking the law. Having said that, it is to not open them without consent. So what we do, as you outlined, is ask for consent. And if it's not received within 30 days, we do work with Canada Post, as well as our RCMP colleagues, in order to determine what to do with the package. Although we can't open it, Canada Post may be able to, and working with police of jurisdiction, have a different approach to dealing with it. Our primary role is to ensure it does not get into the domestic stream, and that's what we do in preventing that.
Would you recommend that we change that legislation to permit CBSA to open packages under 30 grams?
So as part of the ongoing review of what we do with regards to our own mandate and with the work we're doing with our partners, reviewing and looking at legislation is part of the work that we're doing to see if whether or not this will be one of the options in the way forward against this crisis, but in the general management of our mandate.
Well, I'll tell you what, if I wanted to export fentanyl into Canada and I knew about this, I would be sending my fentanyl in packages under 30 grams, wouldn't I?
And that is something we're very seized with, and as a result, we do use all the various detection technology tools that I talked about, and my goal is to ensure that if there's something that I suspect is of that type of contraband or something that should not be entering, it does not enter the stream based on my mandate, whether I open it or not.
Right. But the fact is CBSA has to sit there with a package. They may find suspicious. You may x-ray it, and you can't open it. You've got to contact the person sending it, right?
Correct.
I want to turn to the beginning of this process. The best evidence that I've been able to locate is that 10% of opioid users are addicted, and 30% have what's known as opioid use disorder. There's no question that physical dependence happens very quickly. Withdrawal is unpleasant and difficult. So clearly, we need a large injection of funding for treatment, I think, in our country. Ms. Geller, is there any plans in your department to provide increased funding so that we can open up treatment facilities in this country to help people who are addicted to opioids recover?
Certainly within our area of responsibility for First Nations and Inuit health, there has been a significant influx of funds to improve approaches to treatment in areas where we are responsible. There's also been a significant influx of funds to organizations like the CIHR to do some extensive research on what the best approaches to treatment are. Rita could speak more to that, but the CCSA is also doing work in that regard. At the provincial level, I'm aware that BC has been doing some very innovative things. I'm sure you know more about that than I do, including the Premier's announcement last week, I think, of $5 million. So we are within our area of jurisdiction, beyond the First Nations and Inuit health, looking for ways to support the provinces and others in making sure that the treatment that is available is the most efficient.
Is the federal government making any funds available to the provinces?
Oh, sorry for 3 minutes, but we'll have another 5-minute opportunity here. I've talked to the parties, and we'll each have an additional 5 minutes. I would like to ask one very quick question, and that is with respect to the opioid antidote, naloxone. Ms. Geller, I don't know who to ask this question, Ms. Sharma, with regard to the availability. I know that our police enforcement people, they carry naloxone. I don't know if they all do or not. Our first responders, would it not be a good idea to have perhaps our safe injection sites have that drug as well, or perhaps why can't it be distributed out there more than it is right now?
So in terms of naloxone, there's two forms. There's the injectable form, and now there's the nasal spray form. And we did take steps to make that the form available without a prescription. So that's significantly aided access. Naloxone was already being used in areas such as supervised injection sites, as well as by first responders and in emergency departments. So that was already available. And now there are various strategies that are underway to be able to increase the access. Many provinces have undertaken providing the naloxone free of charge. They will put naloxone either in the injectable form or now in the nasal spray form in specific kits with instructions on how to use it. So certainly I think the steps that have already been taken have increased access already, and I think we will see increased access to both forms as well as we move forward.
That's great to hear. Thank you. So I'll pass it on now to Mr. Ron McKinnon, 5 minutes.
Thank you, Chair. I'm going to go off in a little bit of a different direction here. Historically, our approach to drugs and drug addiction has been to control substances that we consider addictive, highly addictive, and dangerous in that sense. However, in recent years, there's been research done by people such as, I think it's Dr. Bruce Alexander in Vancouver and Gabor Mate, who suggests that the problem of addiction is, the addictive, people get addicted not because of the substances, but because they lack human connections, that you address the human connections in their lives, you improve their quality of life, and they're no longer addicted, or they're no longer susceptible to addiction. So I guess my question here is to the Center for Substance Abuse and probably also to the Health Department. Are you aware of these studies? Do you have an opinion on them? And if you would share that with me.
I could begin, and please others add. Certainly when we look at prevention, we look at risk and protective factors. And I think what was recently mentioned, for instance, looking at resiliency. When you look at the risk factors, some of the risk factors are genetic, some of the risk factors are the environment. When you look at protective factors, it speaks to connectivity in the school, it speaks to connectivity and parental nurturance at home. So there are a listing that, yes, we do consider when we look at prevention practices that look at both the risk factors as well as the protective factors.
Are you familiar with Dr. Alexander's work?
Gabor, I'm familiar with the second individual that you
Okay.
mentioned, yes.
Okay. How about the health department? Have you?
I don't think I have much to add to what Rita just said, to be honest. Certainly we are, aware of the literature around the root causes of substance abuse disorders and keep on top of that. And I think some of that thinking perhaps is behind different countries take different approaches on their drug policies.
Yeah. Because it seems to me if we're wrong about what causes addiction, then we would likely go off in different directions, wrong directions perhaps, in how to treat it and how to prevent it. So if we are in fact focusing wrongly on the substances when we should be focusing more on the people, that would affect our ability to educate people in the problem, to treat people, and to prevent the occurrence. Can you either organizations offer any more insight into this?
I hate to repeat what I had said earlier. I think it's both. I think we need to look at the prevention opportunities that are there. But we also need to look at current practices as well, whether those practices be in education and prescribing or whether those practices be in the delivery of treatment services.
Okay. Those are my questions.
All right, you've got a minute and 36, if okay. Ms. Sidhu.
I just want to let the committee know I have given notice to following motion with the clerk for discussion on Thursday. I move that pursuant to Standing Order 108, the Standing Committee on Health call upon the Minister of Health to move as quickly as possible to conduct a review of the laws and regulations in place with regards to safe injection sites. This review should have as an end goal to improve the health and safety of Canadians using a strong evidence-based approach.
Ms. Sidhu, it'll be distributed to the entire committee here for our next meeting. So let's move on now to Dr. Carey or Ms. Harder for 5 minutes.
That will split our time. Maybe that you can see that the Liberals are really trying to focus on this one thing as far as the spectrum of treatment, safe injection sites. And that's what I wanted to ask a question on, because Ms. Geller was quite correct when she said these safe injection sites, there's no evidence of increased crime rates. But I'd like to ask the RCMP if you could get back to us with statistics. I don't think you'll have them. But my understanding is where Insight is in Vancouver, the police actually have been suggested that they don't charge. So in other words, if they're not charging for all the crimes that they see, the crime rates will not go up. I actually had the opportunity, I went down there unannounced, and it was amazing how many ongoing crimes that you're seeing, but they just don't charge them for it. So I was wondering if you could get some of those statistics back to us, because one of the reasons for putting these safe injection sites into communities, they say it won't increase the crime rate, but we do know that addicts usually are not people of means. In my understanding, to get their hit for the day, they have to commit between 4 and 8 crimes. So if this is something that it's petty crime, prostitution, or whatever they need to do, break and enter, wherever you locate that safe injection site within the area around it, it will cause an increased crime. And the police officers that we had a chance to even talk to down there, they said that there's all kinds of petty crime down there. So I think it's really important when you're looking at C2, that the communities, the neighborhoods, the mums and dads, the kids in the area, that public safety is balanced with just the desire to put these through. So is that statistics, or is that information you could get back to us?
That's something, just because of the location of the specific one we're discussing now is located in the Vancouver City Police jurisdiction, which is not an RCMP jurisdiction. So we'd have to actually go to another police force or jurisdiction and ask them if they have the stats on that, because it's not something we would keep. It'd be within it would be within the City of Vancouver's database.
Yeah. I'd like to find it out just to confirm that, because that's a really important point to bring that forward. The other quick question, Madame Geller, we do find that, or we understand that a major source of fentanyl is from China. I was wondering, can you confirm that fentanyl was not brought up on the recent Chinese visit with the Prime Minister to China, or do you have any knowledge of that?
I'm afraid I have no knowledge of that.
Would you be able to find out for us? Get it back to us?
I can certainly make an inquiry.
That'd be
How
great.
successful I will be, I don't know. But
never hurts to ask.
Never hurts
Thank you
to
very
ask.
much.
Okay. Sorry, just a really quick point of clarification. I think it was you, Ms. Geller. You stated that 2 to 4% of young people misuse or abuse. Is that correct? Were you the one that gave that stat?
Yes, I could pull up the statistics. This comes from the Student Drug Survey, which is now was recently released.
Is there any chance of us getting that report sent to the committee?
It's absolutely consented, and it's actually posted online.
Okay.
But yeah, we can send.
So that's
we can send the report. Yeah.
No, that's great. Thank you. And I guess my last question then here to close off, I guess would come back to you, Rita, and that is, I'm just wondering, Mr. Oliver summed this up really well in terms of these 3 different groups of users. I find that framework helpful. I'm just wondering, with regards to young experimenters, this is a group that I'm very passionate about. What would be the recommendation there in terms of helping to, I guess, prevent the use and abuse of opioids?
I would look at it as preventing or the use and abuse of any psychoactive substance. So I would put it as part of a bigger, I think opioids is one of them that we're dealing with today. Meth was in the past, heroin was in the past, so I think we need to look at it as I had mentioned earlier, what are some of the prevention initiatives that are proven in the evidence that address both the risk and protective factors. As to now, we have done with respect to different substances. We did what youth think about cannabis, for example, and then we need to address how we deliver those messages in a way that resonates with the youth. We're doing the same thing as it pertains to alcohol, and then deliver messages that resonate with the youth pertaining to alcohol. So your question is a good one in the sense that we need to look at different substances to tailor our messaging. But the general framework that we use is the same in terms of prevention initiatives. We need to look at risk and protective factors, but tailor our messaging based on the particular substance.
Okay, thank you.
Great, thank you. And we'll move on now to Mr. Don Davies for 5 minutes.
Thank you, Mr. Chair. So, Ms. Geller, I'll give you a chance to answer that question. Are there any federal funds planned to give to the provinces to help them open detox or treatment facilities that you're aware of?
I'm not aware of funds beyond all of the existing government programs.
Thank you. Assistant Commissioner Sheen, you, I think I've read that the RCMP has would like to see their controls brought in on high-volume pill presses in this country. Can you confirm that for me and maybe elaborate on that?
I've been involved in discussions, as I said, when legislation comes forward, to inform discussions on some of the things that we're seeing, and I've been involved in projects in the past through my involvement with the G7 when we looked at equipment. So when we're asked to inform discussions, we inform discussions on some of the equipment that's being used, so that a determination can be made if that would be appropriate to include in future legislation.
Okay. Now, I think there's broad agreement, I think, from all sources that we don't have a national data collection registry. We don't really know how many people are dying of opioid overdoses. We don't really have clear information on prescription practices, etc. Maybe Mr. Diverty or Ms. Geller, either of you, what steps would you suggest we take I guess first, do we need to have national data on this issue? And if so, how do we go about getting that data?
I think it's, thank you for the question. I think it's critical that we have national data. I think that you have the opportunity through national data to understand the problem in the whole of the country, to compare our situation to that of other countries, and also an ability to compare between jurisdictions to the extent of the issue and that sort of thing. One of the challenges, I think, if we start with on the harm side, you've got death data, and detecting that a death is the result of opioid poisoning is challenging. We're working on some guidelines for coroners with their participation to help standardize that. But you can have dramatically different results on a death certificate around cause of death depending on who the coroner is. So we really don't have comparable data nationally. We need to work on that. When we look on the drug claim side of, which is one part of the supply equation, again, we're working towards nationally comparable data for all drug claims. One of the things where we don't have nationally comparable data is in private prescription claims. We only have that for 3 provinces at the moment. And again, through some of the new electronic records drug information systems, we ought to have that soon. So these are priority areas that we're working on now, and part of the investment from Health Canada, from the government, is directed towards those aims.
Thanks. Ms. Notarandrea, if you could suggest one measure that we could take quickly that may have some immediate impact or effect on saving people's lives from opioid overdoses, what would that be?
After I've been giving all the messages about a comprehensive approach, now zero in on one.
Try to prioritize.
I would say what has been mentioned in that is a national drug observatory. Included in that is prescription monitoring programs in each jurisdiction, and included in that is an early warning system. We need to have the data. And as I mentioned earlier, we have it for physical health issues. If there's a flu across Canada, we can zero in on where the pockets of flu are. We need the same kind of data when we talk about substance use disorders and when we talk specifically about what we're dealing with today, opioids and opioid deaths. So if I had to really zero in, that would.
Thank you. So I think I have time for one more question. I want to talk about prescribing guidelines. In the U.S., new opioid prescribing guidelines were released by the CDC in March of this year that focused on rationalizing prescribing practices and patient education. The College of Physicians and Surgeons in British Columbia has released new professional standards and guidelines that are closely modeled on those guidelines. I'm told the BC standards are more strict than Canada's national guidelines, which have not been revised since 2010, and that they may be out of date with current research associated with taking painkillers. I know that the guidelines are expected to be updated in January, but given the severity of the overdose crisis, Ms. Geller, do you think that we could or should be speeding up that process so that we can update our national prescribing guidelines?
Thank you for the question. Yes, the updating of Canada's national prescribing guidelines, which I think date from 2010, if I'm correct, was one of the initiatives that was funded out of the 2014 budget. It is very close to finalization. I think it's just going through final peer review process, which is obviously an important final step. And there's also a lot of work being done to help ensure that it ends up in the hands of prescribers very quickly after these guidelines are in place. I think that's a very important step. The U.S. Surgeon General, I don't know if you're aware, wrote to every single physician in the United States to provide copies of the guidelines in very easy-to-use form. That's certainly something that we would like to see here as well. And we are hopeful that other provincial physician regulators will copy British Columbia and perhaps adopt the new Canadian guidelines as a standard of practice, because that is one of the key ways to try and get at one of the key root causes behind this problem, which is physician prescribing.
Great. Thank you. We've got one more minute. I'm going to ask a very quick question to Ms. Xavier here. What percentage of the postal stream that comes in internationally is tested and traced for opioids.
All mail, both postal and courier, must be presented to the CBSA, and we use a risk assessment lens. But in terms of any mail coming in from Asia, we are looking at it at 100% as a result of knowing that that's one of our high-risk areas.
I see. Once it's detected, you find a package. Obviously, it then is passed over to our law enforcement agencies. They, from there, continue on with this and perhaps try to make an arrest here in the country. Is that how it works?
Correct. So when we do seize a package and have determined that it has potential links to organized crime or it's breaking a particular contraband law, we do work with our police of local jurisdiction or our CMP colleagues and then share that information. And from that, there are decisions that are made as to how to get to the source aspect of it.
Great. Well, thank you very much. I appreciate everyone coming today, and that concludes our day, and we will be back on Thursday to continue this study. So thank you very much, and I will conclude the meeting. Thank you.
Thank you. Yeah.